Hi, my name is Ed Septimus. I'm in the Department of Population Medicine at Harvard Medical School. Part 3 of these webinars, entitled Pneumonia Diagnostics, the Pathway to Innovation, which I hope will show how these newer, more rapid diagnostic tests can aid us in making better choices. And this is a slide that I think we're all very familiar with. Knowing what the patient's history is important, where they've been. Is anybody else ill? Have they had prior antibiotic exposure? Have they been colonized with organisms? History of MRSA may be very important in your initial therapeutic decisions. You want to know what's going on within your hospital and your susceptibilities in your community when a patient comes in from the outside or if a patient gets an infection in the hospital. And as you can see here, through typical microbiology, it takes usually 2 to 4 days to get the results. On the other hand, some of these more rapid diagnostic platforms can give us results in as early as 2 to 4 hours, but certainly within 24 hours. The other thing is we want to take into account if they've been in the hospital, have they undergone invasive procedures? Do they have lines and catheters? Are they on ventilators? Obviously, nursing workload is important. Staffing is very, very important. Are they intubated? Okay. And again, one of the limitations of traditional cultures is shown on the right. There's a 2 to 4 day lapse. The sensitivity may be low depending upon the site of the infection. And so the diagnostic yield is low. And this is a slide that we've shown before. And what we really want to concentrate on is how can we leverage diagnostic stewardship and antimicrobial stewardship along with these more rapid diagnostic tests. And again, I always want to tell everyone that you always have to apply this to the bedside. So by way of historical perspective, the first bacteria that was cultivated was by Joseph Lister, and that was in 1880. And something that we still use today, the Gram stain, was discovered by Hans Christian Gram in 1884. And then we now began to get new dishes, if you would, to be able to culture. As you all know, that was the Petri dish. And that was in 1887. We've already discussed some of the challenges with pneumonia, especially community-acquired pneumonia, and to some extent healthcare-associated pneumonias. Blood cultures give us a very low yield, and in a low-yield situation, we may have more contaminants than we have real pathogens, which also, by the way, drives inappropriate therapy. Sputums are often not available. Obviously, if patients on the ventilator, we have a much better access to the lower respiratory tract. And again, urinary antigens, again, for a community-acquired pneumonia work for pneumococcus and for Legionella. Again, a slide that we showed you earlier just to remind everyone that now we have the ability to actually culture for viruses, and you can see viruses may be important either by themselves or co-bacterial infections, but with more traditional techniques, we still have about 50+% of patients who come in with community-acquired pneumonia. They were unable to identify the pathogen, and that sort of drives empiric therapy, which may also drive overuse of antibiotics. So we now have the availability of a number of syndromic panels. We refer to the upper respiratory viral panels, which have been very useful in trying to diagnose viral causes. We have bloodstream panels. We have GI and meningitis encephalitis panels. But more recently, we now have a lower respiratory or pneumonia panel, which has been very useful where it's been appropriately applied. And so this is the conventional versus the syndromic testing. Conventional is on the top. You take a specimen, it could be blood or sputum. We can look at the Gram stain. We'll start empiric antimicrobial therapy based on a number of guidelines, and we'll usually continue that for about 2 to 3 days. Unless there's a positive blood culture, we won't get much information back for 3 or 4 days, and it's not until about day 4 that we actually may go from empiric therapy down to what I think is ideal, which is targeted therapy, now that we have the pathogen. Again, to remind everybody, in most cases, we only identify a pathogen by traditional methods in about 50% of cases. Now, if we add the syndromic testing, we can take a specimen, we can still do a Gram stain, but now we can do more rapid identification, and we can actually look for resistance genes at the same time, which is really great. And if it's a positive blood culture, we can do molecular studies on that blood culture and tell you what the organism is and if they have a resistance gene. But now we also have ones for the lower respiratory tract. So we're able within 24 hours to go from empiric therapy to targeted therapy. Compare that to the more traditional therapy, which is shown at the top of the slide. So really marked improvement as well. Now, the syndromic panels are great. They can do simultaneous testing on multiple pathogens. It can be very sensitive specific. It's certainly rapid. And there's always that issue about cost versus value. And I want to emphasize again, that combining diagnostic stewardship and antimicrobial stewardship is critical to get that value added. So when you get the results of one of these new molecular syndromic panels, that it's actionable and you actually move from empiric to targeted much earlier. Now, just to be on the balance side, there are a few cons to these panels. One, you only see what's on the panel. So some panels have certain organisms and some panels have other organisms. So you have to know what the panels will detect. There's always that push and pull between cost and value. As I said, the cost really is much more manageable if you have stewardship really helping drive getting things changed in a real-time manner. The cost really is much more manageable if you have that combination. In some cases, by the way, you may get a result that doesn't change the therapy. However, in most cases, we go from empiric therapy to target therapy in the majority of cases. Here are the two major multiplex channels available for pneumonia. There's the BioFire and the Uvero panel on the right. You can see that one of them, you can get the results in less than an hour and a half. The other one takes a little bit longer, is 5 hours. You can see they detect 15 to 17 bacterial species, 3 atypicals. One can detect 18 resistance genes, one is 10. One can detect 1 fungal, and one can detect viruses. So you have to know what's on your panel in order to decide what the results are. Again, one panel doesn't have any viral targets. The other one does. So you have to know what's on your panel to know how to interpret the results. The performances generally are very good. They're very sensitive. One of the panels does sort of a semi-quantitative result, which really helps improve the specificity. You can see this excellent correlation with sputum and BAL. There are not that many false positives, but there are some. Most of the organisms that they're really good at is Staph aureus, Moraxella, Pseudomonas, H. flu. And as I mentioned, there are a few false positives where it's present on the culture, but not on the multiplex. And some of those are because they're below the cutoff value that I mentioned on the left-hand side of 10 to the 3.5 CFUs. But you can see the majority of them are confirmed. Now, one of the other potential values of this, as I mentioned before, we start off with empiric therapy, but here's a result of actually looking at more hospital onset disease. And you can see one of the great values of getting these results back in a more real-time manner. There's a great opportunity to de-escalate from the empiric therapy that we see so frequently given, such as vancomycin piptazo, vancomycin cefepime. And with the advent of these panels, you can see we can more appropriately de-escalate or discontinue therapy that's no longer necessary. And you can see in a few cases, we can actually appropriately escalate. Again, most of these cases, we're going to be able to de-escalate, but there's a few where we actually need to escalate therapy as well. And then if you look at the pneumonia panel, one of the issues, just like it is for sputums, you still want a high-grade sputum sample. And on the right-hand side, the cytological screening that many of us use. So if you have a poor quality specimen for culture, it's generally going to be a poor quality sputum for these pneumonia panels as well. So I want to sort of summarize all this with a case to show you how all this pulls together, because I think trying to apply things to the bedside, which has been one of my themes throughout these 3 webinars, is really critical. So this is a 32-year-old male who came to our emergency department with 4 to 5 day history of sore throat, low-grade fever, and myalgias, followed by 1 day of increasing shortness of breath and cough. otherwise healthy individual. In the emergency room, he had respiratory distress, he was hypoxic, and he rapidly had to undergo intubation. He had an extensive left-sided consolidation, and by looking at IDSA CDC standards, he was started on a macrolide and a third-generation cephalosporins, which was perfectly consistent with guidelines. And then a rapid test was performed, and I do this live. I always ask the audience what that test was. Well, this particular patient came in on a Sunday afternoon. I came by and I asked the resident to meet me in the microbiology lab. We have a microbiology lab at our facility. And of course, the first question that the resident asked me where it is, because many people don't know where their microbiology lab is. But we went up and actually we looked at the gram stain, which is shown on this particular slide. And you can see that it's gram-positive cocci in clusters. And there are a certain number of patients who get post-viral pneumonias where you can see the pneumococcus, but you can also see Staph aureus. And so the question is, if the patient's on a third-generation cephalosporin and a macrolide, and the patient ends up having Staph aureus, the question is that MSSA or is it MRSA? Well, by using one of these new molecular panels, you can see here we had a high number of organisms, greater than 10 to the 7th in this particular example, and because it could detect resistance genes, this particular patient had the MEK-A gene, so we knew that this patient was MRSA, and we knew that several hours after I saw the patient. So we were able to appropriately, in this case, escalate the patient to vancomycin, and we were able to stop the other antibiotics. So here we went from empiric therapy that was started in the emergency room in the mid part of the day to targeted therapy by 6 p.m. by combining a rapid diagnostic test, which is over 100 years old, the gram stain, in which case I was already suspecting that I may need to cover for MRSA, but I actually got the answer for that by 6 p.m. that afternoon. And if, of course, the MEK-A gene was not present, then I didn't need to use vancomycin, which, as most of you know, even with the new dosing type of programs that are available, can have increased incidence of acute kidney injury. So here's where we leveraged both the typical gram stain with the molecular diagnostic. So I want to end on this particular slide, which I think is, again, one of my themes. That we're all, it's very important about turnaround time. We always want the answer faster and faster. But the real question is, by combining stewardships, that we really want to decrease the time to intervention. Again, if you don't act on the results, then you don't get the value added that these tests provide. So multiple studies have shown, again, one of my themes, that optimal therapy, along with reduced mortality, length of stay, and lower costs, is when you combine these rapid diagnostic tests with an effective local stewardship program. I want to thank all of you for watching this 3-part series. I hope this provided value in your education.